Now the first speaker is Dr. Vrushali Ponde. Everybody knows her. And the topic is local anesthetic pharmacology, adjuvants, toxicity and treatment. Now, she is the organizing secretary of AORA, a focused, committed and innovative anesthesiologist with special interest in pediatric and neonatal anesthesia, ultrasound-guided regional blocks in pediatric as well as adult patients. She is an expert in chronic pain management in children. Actually, she was so obsessed with ultrasound-guided blocks that there is one news which I got that she flicked her cardiologist husband's ultrasound machine and started doing ultrasounds because she was so passionate about it. She has authored a fantastic book titled An Illustrative Manual of USG-Guided Regional Anesthesia. And she has more than 10 international and multiple national present publications. She was a faculty and guest lecturer for NYSORA and ASPA last year. Last but not the least, she is an excellent sitar player. So I now welcome Dr. Vrushali to speak on local anesthetic pharmacology, adjuvants, toxicity and treatment.
Well, we straight get on to the topic now. Job given to me is local anesthetic pharmacology, adjuvants, toxicity, and treatment. We are going to concentrate on the later half since that matters the most. There's one anecdote that I would want to share with you. There was this intelligent pharmacologist and a scientist by himself, Paul Greengard. He elegantly demonstrated that acidification of exoplasmic pH increases local anesthetic potency. In other words, local anesthetic acts in their charged form to block the action potential. We all thought it the other way around. He happened to undergo anesthesia himself, and in the matter of chatting with the anesthesiologists, in the matter of the course, he said the same to them, and they said, no, of course not, it's the other form that acts. The argument obviously was put to rest. By a mask being shoved on his face, he was given anesthesia, and that was the end of it. What he meant was this. All that happens at the cellular membrane level is this. This is the cell membrane. The action potential has commenced. The sodium gushes inside the cell. This is our local anesthetic drug molecule, unionized, gets across the cell membrane, comes inside the cell, attaches itself to H ions, and now becomes competent to block the action potential. This is how actually the local anesthetic works, and this is what he meant, which is now obviously a fact. So the important lessons learned here are: always listen to your patients, keep yourself up to date with scientific knowledge. General anesthesia might not be a great way to end an argument, but not to build confidence in your profession. The points that we are going to discuss in the next 20 minutes to come is local anesthetic pharmacology, the newer local anesthetics, possible additives, incidence of local anesthetic toxicity, mechanism of cardiotoxicity, clinical manifestations of toxicity, prevention of local anesthetic toxicity, systemic toxicity is what I meant, recommendation for treatment of local anesthetic systemic toxicity. Well, let me just tell you about the past glory. It's still, of course, basking in glory, but the past glory is as follows. Long time back, people used to chew on cocaine leaves and get a high out of it, but the numbing of oral mucosa, in fact, was a side effect. So the effect of local anesthetic that we now count on actually was a side effect. When it was ultimately crystallized and used and made popular by Sigmund Freud and his colleague Carl Koller, it was in everything for its high. Wine tonics, cocas, everything. So the toxic effects were obviously evident. Local anesthetics was a profound crisis, but then now we indeed are sailing smooth. How come? Because of the newer local anesthetics. The aminoamides, the esters came into picture. and the latest ones, levobupivacaine and ropivacaine. The basics, aromatic portion, amine portion, which are joined by either esters and amides. So we have two groups, the esters and the amides. Well, let's put up with practical relevant points. Potency, duration of action, speed of onset, tendency for differential sensory nerve blocks. So that we get the sensory and leave the motor when we wish to alone. Potency and duration of LA is directly proportional to the molecular weight and lipid solubility. The speed of onset is, we need to understand the pKa below. pKa is the pH at which 50% of molecules are free base and 50% of molecules have a positive charge. The onset of anesthesia decreases with increasing LA lipid solubility and increasing molecular weight. This is how the nerve fibers respond to LA. Blood concentration and pharmacokinetics. LAs are partially protein bound. Newer local anesthetics, why did we need them? That's because of the toxicity that was rampantly seen with bupivacaine, especially the higher dose. Then the FDA gave it a black box warning. So what happens is, as we keep on working with a given drug, a clinician overlooks adverse effects of a drug that has been used in practice for a long time in much a similar manner as one would overlook the shortcomings of a spouse after a decade of marriage. Although the search for an ideal, the local anesthetic, always continues. So what, according to us, would be an ideal local anesthetic? Differential sensory block should be rendered by it. Rapid onset, longer duration, stable without preservatives, virtually non-toxic. It should be cost-effective and also easily available. This is what we would dream of having one. So the newer ones here have come into existence because of the chirality, the stereoisomerism that has been exhibited. So let's look at ropivacaine. It's formulated as a single levoisomer, water-soluble, highly protein-bound, considerably less lipid-soluble than bupivacaine, and hence around 20 to 30% less potent. These are the dosages. But, well, here we go. We did get a cardiotoxicity because of that. But the good news was it was easy to treat. Then came the levobupivacaine. It is a purely levorotatory isomer. In equipotent doses, the worst is the bupivacaine, then comes the levobupivacaine, and then the ropivacaine. So the best amongst it happens to be ropivacaine. Let's look at the adjuvants. I've just made a chart of it so that I could summarize it for you. Let's look at the routes by which the adjuvants can be used and the agent and the doses.